Hello, everybody. Welcome to the Hormone Genius Podcast. And I'm here today with my co-host, Jamie, and super excited. Ultra excited to do this episode because this topic that we're going to talk about is one of my favorite things to talk about because it affects so many women. So I know you're all going to love this. And what's also exciting is that I'm going to be asked questions by Jamie, and I don't know what they are. So always love this. We're going to do the rapid fire question and answer session with Teresa Kenney, nurse practitioner. And our topic today is what, Jamie?
It's PCOS, also known as polycystic ovarian disease or syndrome, depending on which way you want to swing it. That might be my first question for you. So Can I dig in?
You can dig in, girl.
Get rolling. Okay, so which is it, Teresa? I've heard it so many ways.
I know. So like the cool kids now call it PCOS.
Oh, PCOS.
Yes. So that's the newest version of it. So I think what's more commonly understood terminology is PCOS or polycystic ovarian syndrome. And I think the reason why this fits a little bit more is because, anytime we talk about a syndrome, there is this kind of this idea that there's an umbrella to it, that you may have parts of the condition and not all parts of the condition, but you fit under this umbrella of what we call PCOS or the polycystic ovarian syndrome. So that's the main reason. I think it just fits kind of the overall idea that this isn't just a one size fits all disease. And I know that just in practice, we see all sorts of kind of versions of PCOS come to us as patients.
Okay, so that's really helpful, I think, for the listeners and for me. So when I learned about PCOS, I heard it as PCOD. And so if those of you have heard PCOD, or maybe you've been diagnosed with PCOD, polycystic ovarian disease, really different. PCOS, or the same actually. Different letter, but we're talking about the same thing.
Same thing. Yep, absolutely.
Cool. Okay, so let's start off. What is PCOS? What is polycystic ovarian syndrome?
Right. Well, so what's interesting about this is you would think that when we say polycystic ovarian syndrome, we're talking about the ovaries, right? We're talking about the physical change in the ovaries that's happening. And poly means many, and cis, of course, are things, little fluid-filled structures on the ovary. But what's crazy about PCOS is that's not really the heart of the condition. It's not having a polycystic ovary. The heart of the condition really is an endocrine or metabolic disorder, which I would say causes a cascade of hormonal imbalances that leads to a lot of ill effects in the woman's body. So for example, the woman that walks in the door most often to see us is a patient that basically has irregular cycles. So that part of the condition of PCOS is that women come and they're not ovulating regularly, because what causes periods? Regular ovulation. So first and foremost, the main symptom that women would come in kind of distressed about is the fact that their cycles aren't regular, and especially younger women, because they started their periods, maybe they were 12 or 13, and then all of a sudden they're not having a period once a month. Now it's coming once every 3 months or once every 6 months even. And this is somewhat distressing, of course, to them because they know that's not normal.
Right.
The second thing that women present with, and this is probably the most important thing to some degree, is male symptoms or male hormone symptoms, what we call in the medical world androgen excess symptoms. So acne and increased hair growth would be the two most common. Sometimes even hair loss, kind of referred to as a male pattern hair loss, is common. And why does this happen? Well, because of this imbalance in the hormones, the male-like hormones basically get pushed up in the woman's body. And that actually happens because of a first hormone becoming out of balance called insulin. But as the hormone levels of testosterone and DHEA, which are two male-like hormones, go up, women start to notice these symptoms of male-like effect: acne, hair growth, not fun, and no woman wants to have that. So that's also distressing, and they might come in and say, why am I having all these pimples and I just don't understand? I do everything and they don't go away, or I'm noticing there's chin hairs all over the place, or I get hair around my belly, or even hair around the breasts or nipples. Those are all symptoms potentially of this syndrome, especially again if it's causing a disruption in ovulation as well.
Right. Okay, very cool. So what causes, I know you kind of touched on this just a little bit, but what would cause PCOS? Is this like, well, that's the first question. Then I'm going to ask a follow-up question to that.
So we don't really, I mean, what causes it is somewhat unknown. We know kind of what is happening from the endocrine standpoint when things are getting off. Like we know that there's this insulin resistance that occurs with PCOS. We know that that drives up male-like hormones like testosterone, but what causes it originally is unknown to some degree. Okay. Now, there's speculation and theories out there about what causes PCOS. I personally am drawn to the idea that this has to do with a couple of different things. One would be genetics. So we all have different genetics, and we all, because of our genes, are going to be prone to certain diseases, you could say, certain conditions based on those genetics. And we know that PCOS runs in families. So for this condition, if your mom had it, if your sisters have it, you definitely are more likely to have it yourself. Secondly would be, and I think this is the most important, is environmental changes and the lifestyle. So there's a speculation that maybe women whose mothers were on birth control that had a high amount of androgens in them could actually have, led to the baby getting an exposure to that in utero. Or that there's environmental toxins that we call endocrine system disruptors that also may be playing a role in how our hormones are acting. I mean, it kind of makes sense. Something is simple or as toxic as BPA, which we know is in plastics, and we're all concerned about that from an environmental perspective, actually is an endocrine system disruptor. Yeah. And so we have all of these toxins in our environment that women are exposed to more now than ever. And this is probably why this condition, PCOS, is the most common endocrine disease diagnosed in women. And I've seen anywhere from 1 in 10 women all the way down to 1 in 5 women are diagnosed with this. So it's definitely on the rise. And so we have to ask the question is, what's changed in the last 100 years? Yeah. Well, the environment has changed, and all of the toxins in the environment, certainly. And then our diets have changed. So this is the other part of it. So the standard American diet, like we know that is pretty significant in a lot of diseases for health. But we do think that this could also be a factor in polycystic ovarian syndrome, especially if you are genetically prone to it. So a standard American diet, processed foods, lots of flours, starches, lots of processed sugars, less vegetables, less fiber, and less healthy fats, and more unhealthy fats can lead to a lot of changes in the body. So again, those are some of the things that we think could be leading to this condition. But it definitely shows up for the most part in young women. So we see them around 15, 16, all the way into their early 20s.
Teresa, that's surprising to me. Or it's surprising, but yeah, I think it's alarming. That's a better word for it. It's alarming. It's alarming that such young girls are experiencing that already. Can you speak a little bit to, when we hear the phrase Xenoestrogens, Xeno estrogen, can you talk a little bit about that and how that's connected to like an estrogen dominance thing? And you kind of just answered it.
Yeah. Right. So another kind of word you could say for the endocrine system disruptor, but a xenoestrogen is basically anything that's in the environment as a chemical that could mimic or closely resemble enough actual estrogen that it can affect the receptor sites of where estrogen basically is in our body. So, you have like BPA and now someone's, had a lot of exposure to that through cans or plastics and things like that. And then their receptor sites in their body, they're exposed to all these chemicals that kind of mimic a little bit the properties of a hormone. And all of a sudden you've got dysfunction now at those receptor sites. Right. And that's another thing they're seeing with PCOS is they're seeing the receptor sites of their hormones are dysfunctional. And another thing we're seeing with PCOS that, again, is not really understood is that there's a lot of pro-inflammatory markers going on. So the most kind of like common inflammatory marker we measure in people is C-reactive protein. And, a lot of times this is used to determine if someone has a cardiovascular issue, but in PCOS, we're seeing that marker is elevated in the vast majority of women with PCOS. So there's definitely this inflammatory kind of issue as well going on with women with PCOS.
Oh my goodness. I'm writing this down, so don't forget. That's something I did not realize was the C-reactive protein. Okay, so we talked about what PCOS is. We talked about kind of the causes and some of the unknowns, but some of the maybe correlations that we can draw between the two. And we also talked a little bit about like the signs by just maybe just looking, if a woman has acne and hair growth and that kind of thing. What can you say about PCOS in the women that might not have those physical symptoms? And how would a woman know without having those physical symptoms that she has PCOS? Or even women who do have those physical symptoms, what's that process for that woman finding that out?
Yeah, I mean, it's interesting. I'm just working with a patient right now in this kind of situation where she started to see me and she was charting her cycles. And this, of course, foundational to like us knowing what's going on in her body, right, is the charting. And that's, we talk about this so much on this podcast, is women knowing their bodies, so foundational to understanding the root cause of disease. So this woman came to me, she's learning how to chart, she's preparing to get married, and she's noticing some, subtle changes in her cycle. She is having somewhat of a regular cycle, but she had an ovarian cyst that was painful that kind of came up out of nowhere. She's having a lot of stress. There's some signs of inflammation, some abnormal bleeding. And she's a thin woman, some acne, but nothing kind of extreme. And ultimately, after a period of time of working with her and doing some other testing, we're finding that she is falling under that umbrella of PCOS. Mm-hmm. So this is why it's so important to get an accurate diagnosis. Mm-hmm. So if your doctor looks at you and just says, well, you have PCOS, that is not an accurate way to get a diagnosis. I see, again, a lot of women who have skinny PCOS. So we often think you have to be overweight to have PCOS. Yeah. Mm-hmm. And that's not the case. We see actually a lot of women with normal body weight who do exhibit symptoms and markers for PCOS. Now, those skinny women actually, though, can still have insulin resistance. Mm-hmm. And this is important because, we know that PCOS, kind of the hallmark dysfunction is insulin resistance to start off. It's the inability of the woman's body to use insulin effectively to kind of like lock and key receptor to sugar or glucose and basically use energy. And so insulin levels get driven up in women with PCOS, which drives up testosterone. So that's kind of the pathway there. But insulin resistance is kind of the home, you could say, place where the dysfunction starts. But again, you don't have to be overweight to have insulin resistance. Mm-hmm. Women who are overweight almost likely have insulin resistance. We do know that. But the skinny PCOS patients, about 40 to up to even 70% may have some mild to moderate insulin resistance. And that's super important. Why? One, it's kind of where we need to target our treatment, mm-hmm. because insulin resistance promotes inflammation in the body, and it also promotes the woman's inability to ovulate regularly. Mm-hmm. So we need to focus our treatment there. And two, we need to basically help her to get to, again, a regular cycle, healthy ovulation, and address those issues that affect her the most. And so we really want to target that piece. So testing is super important in getting an accurate diagnosis. And we could, go over kind of how you test for that if you want to, Jamie. But do you have any questions about that?
Well, I'm glad you kind of gave that recap of just, there's not like a one look sort of PCOS. It could look in many ways, but what kind of lab work would a woman get? What would be off in her labs if she had PCOS?
Yeah. So if you're going to your doctor and you have some irregularity to your cycles, or you have this androgen excess and you're like, I'm really wondering if I have this condition, PCOS, there's basically some blood work that can really help. And we want to measure first and foremost male-like hormones. Testosterone, DHEA, and androstenedione are the three male hormones. Well, actually one more, sex-binding hormone globulin as well. So those four can be measured and really can give us an idea of if PCOS is likely a condition. Mm-hmm. The other thing would be your pituitary hormones, FSH and LH. because these are the hormones that basically regulate your menstrual cycle. They're the pacemaker hormones of the body. And when we have PCOS, again, related to the insulin resistance, LH gets driven up. And what we'll see is that LH is going to be produced in higher amounts than FSH when you have PCOS. Classically in a 3-to-1 ratio, although I see it doesn't have to be that way always. And then thirdly, we want to make sure we're also testing for other things that cause irregular cycles. You don't want to miss another diagnosis, obviously, that could cause irregularity. So we have to test things like prolactin levels, thyroid levels, and you even have to be aware that there is a certain amount of adrenal issues that can cause, excess androgens. We got to rule out things like congenital adrenal hyperplasia, which is rare, but certainly should be investigated if symptoms are there and markers are there. So those are the main, basically, hormones that we draw. And, when we get results, we have to put that with other things. We put it with the cycle patterns, the symptoms of the patient, and then the last piece is the ultrasound. And this is where it gets a little tricky. Because you think, well, in order to know if I have PCOS, you would have to have polycystic ovaries, right? Because again, the condition is called polycystic ovaries, but that's actually not the case. And so I would just be careful to let women know that if your doctor is said you don't have any cysts on your ovaries, that may still not mean, that doesn't negate the fact that you could still have PCOS. And 2, if a doctor told you you have a bunch of cysts on your ovaries, you still may not have PCOS. So just the ultrasound alone cannot make the diagnosis. And there are other conditions that can cause the cysts on the ovaries. For example, and this I see often in my younger patients. So I'll give you an example of like a college age girl that has come to me. And all of a sudden, she gets to college and her cycles become super irregular. And maybe now she hasn't had a period in like 6 months. And she comes, she's trying to figure out what's going on. Well, there is a condition called hypothalamic amenorrhea. It's caused a lot of times by significant stress, and it can drop the hormone levels down enough that actually stops the cycles, but it also can make the cysts on the ovary appear. So you can have polycystic looking ovaries and have this condition, hypothalamic amenorrhea, which I actually see often. And so you want to be careful you don't get a misdiagnosis too between PCOS and this other condition. So it takes a good healthcare practitioner to get a good and accurate diagnosis, is the kind of key point takeaway.
Oh my gosh, Teresa, you are so smart. You are so smart, and our listeners are so blessed that they're learning all of this from you so that if this is something they're experiencing, they can be sure to start charting. And I have more questions for you, but begin to start charting if you're not already. People think about that. And then B, kind of interview some doctors, search around if your physician isn't open to maybe learning more about this. Okay, so what can women do who have PCOS? So if you're listening, ladies, and you're like, oh my gosh, I have PCOS, I'm doomed. Don't think you're doomed. We're going to kind of walk through this. Teresa's going to walk through this with you. So what's something that women who have PCOS can start trying?
Yeah. And that
struggling, I'm sorry too, just also just health-wise, but then also those who are working to achieve pregnancy.
Absolutely. Yeah. Because I think and that's the key. There's so much hope here. And I don't want women to be discouraged because it can be a really frustrating condition. And I want women to know that there is definitely not only treatment, but there's things that you can do to empower yourself to take care of your own body as a woman as well in relationship to this condition, especially. And I, just on the phone today with a patient, and I had given her the diagnosis of PCOS. And the first thing she said is, does this mean I have infertility? So I know that not for every woman, maybe in that moment they get the diagnosis, but a lot of women, their heart says, oh my gosh, does this mean I'm never going to be able to have children? And the answer is no. The answer is yes, you'll be able to have children. I guess I'd say that right. Yes. There's so much hope in this condition. And I would say in my practice, PCOS is probably our most successful place where we treat infertility. So a lot of hope in that area. And there's a lot of treatments that we can do to help women. But I'd like to speak especially just again to that younger woman before she, ever is thinking about having children. What can she do with that condition and that diagnosis? First and foremost, chart your cycles. Again, the key is that whether you can have a baby depends on whether you ovulate. And when you have regular periods, that means you have, to some degree, the sign of healthy ovulation. And with PCOS, we know that irregularity in your cycles has to do with infrequent ovulation. And so you're not going to know whether you're fertile or infertile or whether you're ovulating unless you chart, because we have to be able to find that sign of ovulation, which, for Jamie and I, cervical mucus is the one that we teach in the Creighton model system. So, but however you do it, you have to understand what's going on in your body with PCOS. So charting is first. Number 2, you don't need birth control to treat this condition. And that I think, could you take birth control? And maybe that would be an answer for you. Yes, but this is not what you need to basically control the condition. And that's what a lot of women go to their doctors and they get the diagnosis and the doctor's like, you need 2 things, metformin and birth control. And that's not really the truth. You don't need either of those to survive with PCOS. And there are a lot of alternatives, healthy alternatives that women can put in place to use as an alternative to those 2 things. But the metformin, which is a medication that treats insulin resistance, it is important to address that part of the condition. So let's say, there are times I use metformin. And when someone has really bad insulin resistance, it's a great medication. It's very safe. It does increase ovulation patterns. So that is a good medication for some women. But I have a lot of younger women, again, high school, college, and they're like, I don't really want to be on drugs. I don't want to be on any medication. So what can I do for them? Well, diet and lifestyle, obviously key. So what we do is we look at their diet and we say, what can we do to help kind of, again, decrease inflammation and decrease insulin resistance? Often I'll recommend something similar to a paleo diet. And I'm not saying every patient needs to go out and eat a paleo diet and that's the answer. But the paleo diet does represent a lot of the kind of anti-inflammatory eating lifestyles that help with insulin resistance. What does that mean? Taking out a lot of processed foods that are made with flour and high fructose corn syrup, which is really bad for you. And basically, all the baked goods and things like that. Number 1, that's super important. Adding back lots of vegetables and fiber, because fiber decreases insulin resistance. And drinking lots of water and not drinking sugar is so important. So the paleo diet at least gives us kind of an idea of a lifestyle that you could follow. Are there other eating anti-inflammatory diets that you could follow? Whole30, a Mediterranean diet. There are other options. So what I do is I work with my patients to find the best kind of anti-inflammatory eating lifestyle that they would be happy to follow. So that's important for decreasing insulin resistance. And that alone, in and of itself, with healthy exercise, can actually change the whole scope of PCOS. So again, empowerment. Women can take charge of those 2 things and make a huge difference. Totally. But let's say we need a little bit more help with the insulin resistance. There are some supplements that are out there, very good, very well researched, that help with insulin resistance and kind of the imbalance of the hormones with PCOS. One of my favorites, myo-inositol. Have you heard of it, Jamie?
Is it like an anti-inflammatory?
It probably does have a little anti-inflammatory element. It is a polysaccharide / B vitamin. You could put it into the B vitamins. But it's, some people will hear about it from fertility standpoint. So they hear of this medication, or not, the supplement's called ovasitol. There's lots of brands of it now on the market. But myo-inositol has been studied and been found to decrease insulin resistance as effectively as metformin, and to establish healthy ovulation patterns and to decrease even androgen levels. Totally natural. And a woman can buy this over the counter. And I have different brands that I like. But basically if you get the ingredient myo-inositol and you take anywhere from 2,000 to 4,000 milligrams, that's a great start. And what I love about myo-inositol as well is that it helps with anxiety.
Oh my gosh.
So myo-inositol was studied in psychiatric medicine to decrease obsessive compulsive disorder, and was found at high dosages to be as effective as psychiatric medication. So what I know is if I give this supplement to women, they are actually going to have less anxiety. And what do we know about PCOS? Women with PCOS suffer more with anxiety, and depression. We're not sure why, but they definitely do. Number 2, vitamin D. Women with PCOS, I mean, pretty much everybody needs to be on vitamin D, but this is so true of women with PCOS. One, they have found that your vitamin D levels are lower than normal, than the average person, but vitamin D is essential for your thyroid, and it's essential for insulin as well. So you have to have optimal vitamin D levels. And so at the bare minimum, I tell people to take 2,000 IUs of vitamin D daily. But really, it's valuable to get your level tested and try to shoot for a level between 50 and 80 would be ideal. So vitamin D. The third one I love, because I could go on all day about different ones I love, but I can't. But I'll just mention this one is berberine. Berberine is this great natural substance. It's basically a food kind of grade supplement that helps with insulin resistance, helps even with gut health, gut inflammation, the leaky gut syndrome. And in studies, it performed also equally as well as metformin at 500 milligrams 3 times a day. So often I will use, instead of metformin, a combination of berberine, vitamin D, myoinositol, and sometimes I'll add even alpha lipoic acid, which is also great for insulin levels. It's been studied in type 2 diabetes patients. So there's just so much out there that we can do to help kind of really target this condition and bring down, kind of those imbalance levels.
So Teresa, with those supplements that you suggested, is it like an everyday, take it every day, or is there? Okay.
Yeah, these are an everyday thing because again, we're eating every day. So they're basically targeting kind of our, balancing of our insulin, adrenal hormones, thyroid hormones on a daily basis. So all of those can be taken every day. What you might not take every day would be how we regulate menstrual cycles. So let's just say someone has PCOS and they don't have periods hardly ever. We've got to do something about that. Why? Mostly because with PCOS, you are at risk for endometrial cancer, which is the lining of the uterus. And so over a period of time, if someone just doesn't have periods and doesn't shed that lining, they are going to be at risk for uterine cancer. So we do have to address that. And how can we address that without using birth control pills? We can just use bioidentical progesterone in a very cyclic way. And this can be done very easily by having women take progesterone 10 days out of a cycle. Sometimes, it's done less frequently than that, but I like to really schedule it in a cyclic way. Women feel more balanced. Sometimes it does help in establishing healthy ovulation patterns. So progesterone may be a part of treatment with PCOS. Again, bioidentical, natural progesterone.
Totally. Oh my gosh, Teresa, I wrote down so many things. Thank you so much for sharing all about this. So many women are going to feel blessed by this information. Women who are on the pill and they don't want to be on the pill. They're on the pill because of their irregular cycles and they're just praying and looking for an alternative. So whether they're, I guess if you're on the pill, they're probably, not wanting to get pregnant right at this moment. But the blessing as well is if you get your cycle right for women who may be on the pill or whatever other, means to avoid pregnancy at the time, you can chart your cycle to not only understand your feminine health, it's a 5th vital sign, but also to avoid pregnancy if you were using the pill for maybe a couple of reasons, to regulate cycles and for birth control. So the great news about this, Teresa, and to our listeners, I'm just so excited about what we're doing here, just giving women a voice and sharing this noise. So Teresa, thank you for answering these questions. Again, you teach me every single time. We've only done 2 so far, Q&As. Oh my gosh, you guys, I cannot wait to continue learning from Teresa. She's amazing. So again, thank you for hopping on. Listeners, please share this information with people who really, really need this. And in my opinion, every woman in their childbearing years, actually every person in general, because every person knows a woman in their childbearing years, please share this podcast with your friends because again, women deserve this information. So Teresa, thanks for taking time today. Is there any last thing you want to share before we hop off?
No, I just want to say thank you, Jamie. And I feel like we'll have to do like a PCOS 2 because I'm thinking, oh my gosh, there's just so much more we got to share. But yeah, we'll definitely keep hitting this topic. I know this topic is so important to so many women out there. And we're going to touch so many more topics that affect women as well in future podcasts. But yeah, thanks, Jamie, for your kind words and looking forward to doing the next one with you.
Sounds good.